Welcome everyone. I'd like to acknowledge the traditional owners of the lands that we're all meeting on today. For me, it's the Gadigal people of the Eora Nation, and pay my respects to elders past, present and emerging, and acknowledge any Aboriginal people who are joining us here today. I'd like to invite participants to introduce themselves, their organisation and their role and the lands that they're on in the chat function for us today. We're going to be recording the session so that other organisations are able to hear about health justice partnerships and for you to refer back to in the future. And don't forget to put your questions in the Q&A function and your comments in the chat function. My name is Robert Stirling and I'm the CEO of NADA, and I'm really excited about today's presentation. We know that our work with people who access treatment is far greater than reducing alcohol and other drug-related harms. Our members work to identify and respond to the social determinants of health, and that includes responding to justice-related matters. There's the obvious criminal penalties associated with the possession of illicit substances, but there's also other matters, managing fines, family law matters, housing, and other matters. So today's presentation is about hearing about health justice partnerships that can support NADA members to improve care for people who access alcohol and other drug treatment. It's now my pleasure to introduce our speakers. Firstly, Tessa Boyd-Caine. Tessa is the founding CEO of Health Justice Australia, established in 2016 as the National Centre for Excellence for Health Justice Partnership. Originally a criminologist, she's worked in health, criminal justice, human rights organisations in Australia and internationally. Next, Lisa Ward. Lisa is Project Lead, Health Justice Partnerships at First Step Legal. Lisa's career as a social worker and lawyer has traversed a range of services including child protection, youth justice and adult corrections. And Cathy Bucolo. Cathy is the Practice Development Lead at Health Justice Australia, where her roles include convening and supporting the National Health Justice Partnership Practitioner Network. I'd like to now hand over to Kath to facilitate our discussion today. Thank you.
Thank you. Thank you so much. So in Australia, many people experience legal problems. In fact, a landmark national survey in 2012 told us that over 1/5 of people in Australia experience 3 or more legal problems in a given year. These legal problems tend to cluster around experiences like family violence, money problems such as credit and debt, consumer transactions, welfare and benefits, or problems with poor quality housing. Yet many people don't know that legal help is available, or if they know it's available, they don't access it. You'll know from your own work why this might be the case. The person may be flat out dealing with the crisis, the violence, the homelessness, the eviction, whatever might be happening right now. And to go and see another professional or to go to one more appointment, well, that's just too much for them. They may think it costs too much to see a lawyer. I'm not bloody made of money. Rich people have lawyers. The person may have had a terrible experience with a lawyer or with the law in general. I'm not going anywhere near a lawyer or a cop. Last time I did that, I ended up locked up. Others have experienced trauma. Another person may feel shame. They have endured accessibility barriers every single day, both physical and systemic. People feel powerless and many are discriminated against. I'm sure you'll all be thinking of so many more reasons for why the people you support have unmet legal need. This unmet legal need, we know, causes and perpetuates life's problems and harms people's health and well-being. And that means they can again be less likely to seek legal help and the cycle goes around. At Health Justice Australia, we think there's a strong solution to this emerging problem, and we like to talk about it as a bit of a quiet revolution. Because the other significant insight from the survey in 2012 is if people do talk about their legal problems, they talk about them with, and you may be able to guess, a health professional or someone who works in a health service and what we might call a non-legal advisor. That's all of you in residential rehab services, in day programs, in outreach services, in pre and post clinics, in community health, in youth services, in Aboriginal and Torres Strait Islander community controlled health services. Those of you in women's health and in LGBTQIA, transgender and gender diverse services, in primary health, and all the other areas I may have missed. All the practitioners in NADA, you are the people hearing about your client's unmet legal need. But as fabulous as we health professionals are, we ain't no lawyer. In a growing movement, legal assistance services are collaborating with healthcare teams and in healthcare settings to provide free legal help in the services where people go. In other words, there's a growing movement of health justice partnerships being developed. So now we'll hear more. So we've got our lovely panel members here. I'll ask you first, Lisa, can you tell us about health justice partnership and the difference you've seen through this way of working for clients?
Thanks, Cathy. And hi, everyone. It's really good to be here today to talk about a form of lawyering that I'm passionate about and to build some interest in this way of working because as someone who's spent a lot of time working with complex clients with multiple intersecting needs, I'm convinced that integrated ways of working are the only way to go. So really pleased to be having this conversation today. First Step Legal has 4 different health justice partnerships and they all operate differently. And that's important because they have to be sort of scoped towards the needs of both partner organisations. One of our partnerships where we deliver an on-site service to, we're co-located in a mental health and addiction treatment hub called First Step. But our other 3 partners, we deliver services to off-site through a regular session at their service where a lawyer attends the service and where we catch up with clients in between those regular sessions via phone, via teleconferencing, video conferencing, or with them coming into our offices. So today I'll focus particularly on one of our partnerships, which is with Windana Therapeutic Community, a residential drug treatment service, and we've been in partnership with them for a couple of years. I think, Cathy, the best way to explain the work we do is via a story to help illustrate how our work happens in practice. So I'll talk a bit today about the work we've done with a client of Windana called Belinda, who entered the therapeutic community when she was about 22 years old. She was referred to us for assistance with some unpaid fines, a significant volume of unpaid fines that were really weighing heavily on her. And the clinicians felt were really sort of impeding her ability to engage in treatment. At intake, we always conduct a comprehensive needs analysis to see if there's anything else ticking over, which is often the case for people in Belinda's situation. She'd had a period of extended homelessness and really heavy drug use. And we discovered through that process that there was a recent court outcome recorded for an assault matter that Belinda knew nothing about. She didn't know that she'd been charged. She could remember the incident but had no sense that she'd been charged and certainly didn't know that an outcome had been heard in her absence. Our priority in that early stage of working with a client is to identify immediate legal need that has to be addressed, either to take the weight of worry away from the client or to prevent escalation of the legal matter in an unhelpful way. So we really think carefully about what we have to do when. For Belinda, it was most important that we do something about the fines because they were really, really causing her a heap of stress. We were able to apply through what we have in Victoria as a work and development program. I believe there's equivalent in other states that allow you to actually work off your fines through your drug treatment. That meant that at the end of her time in residential rehab, she actually came out with a clean slate. So that was a really important part of our first engagement. What we'll often say to our clients early on is hand us the stress of your legal matters so you can get on with the important part of recovery. And that's absolute gold for many of our clients. From there, we talked to Belinda about the assault charge and we got her instructions to have the matter reheard on the basis that she was homeless at the time and was unaware that the matter was progressing. That was really important because so often people in Belinda's situation accumulate a number of low-level criminal convictions that ultimately escalate their trajectory up the offending hierarchy and see them entering custody way earlier than people in other circumstances. So that early intervention piece of making sure people with serious addiction issues don't accumulate a heap of convictions is vital. We got the assault charge reheard. I think it was in about the 4th month of Belinda's period in treatment. With the court understanding more about her circumstances, we were able to attract a diversion outcome with no criminal conviction. Now, the circumstances around that assault were interesting in themselves, and as Belinda developed trust in us as a service, she was able to really disclose what was going on for her. Effectively, the assault was against a PSO on a train station, and the PSO was called by bystanders in response to the fact that she was being assaulted by her partner of 5 years. The PSO came to her assistance. Her partner had said to her, "Get rid of them," and she became verbally and physically assaultive to the PSO out of fear in the context of that relationship. Over time, it emerged that that relationship was one of significantly coercive behaviour. Her partner had introduced her to illicit substances 5 years earlier, and she remained in a pretty abusive relationship as a result of that dependence. He was her supplier, and there was a lot of violence within the relationship. Over time, through her sort of involvement with her peers at Windana, through her AOD treatment and therapy, she developed a lot better insight into the causes of her substance use and the interplay between her relationships and her substance use, and came back to First Step asking us to assist her in taking out an intervention order against the partner so that she could actually exit from therapeutic treatment with a sort of safe environment around her. So she was really over that journey of treatment starting to prioritise her own health and mental safety. We then applied for an IVO, but importantly as the application for the IVO was working with Belinda to give her some sense of agency in that process. So what we try to do is really give the clients a voice, take their instructions, and wherever possible have them speaking with our support in court and have the magistrate hearing their perspective on the matter. And Belinda said to us in hindsight that that was as important as the court outcome itself, that sense of being heard and of being able to have a little bit more control over the criminal justice process. She left Windana after about 5 months with an IVO in place, returned home to her mum and stepdad, got a driver's licence, got some employment. And then in that post-discharge period, we continued to support her to get some VOCAT, some victims of crime assistance compensation, which in turn paid for some one-on-one counselling and therapy to continue her journey along the way of remaining relatively substance-free, but also to address the trauma that she had accumulated through that really intensive period of persistent drug use and abuse at the hands of her partner. So I chose that particular story because it shows how we can provide a range of legal services over the life of a client matter that weave in and out. The timing of those legal interventions is really important in relation to the therapeutic goals, and that's something I might return to a bit later. But the key message along the way is that it's the clinicians and us having a dialogue around how we proceed with legal matters and therapeutic goals in a way that makes sense from the client's perspective. That's not about head start, and then I might return to some of the details of how we work a bit later.
Thank you so much. Yeah, what a fantastic example, Lisa, because the message of timing comes out like you've said, but I was just making some notes, and really that prevention, early intervention in terms of the phase really is highlighted. I think a partnership working early and then the link of that with client outcomes for Belinda, you know, what that really meant for her. So yeah, early intervention, proactive prevention, those sorts of words that probably in the sector we'd all use. The handing over of stress, as you talked about, but I do wonder for our, the NADA members, it's kind of as a partner, as a health practitioner, as a broad category, handing over that's part of that stress of that situation to a lawyer to kind of do that, manage that and work on that together is really, that kind of struck me too.
I think the other thing that's important there too, Cathy, is that they're handing the workers are handing their stress over to a lawyer they know and trust. So that one of the things our partners often say is that we know you'll carry through. We know the way you work. It's not sort of handing it over to a lawyer who you not familiar with the way of working. So that familiarity is quite important as well, and the continuity of the relationship. We have one worker working with each of our partnership agencies, so there's a sort of trust and continuity that's really important.
Oh, that's fantastic. Yeah, that really makes sense. Great. Well, I feel like we could just keep talking about that, but we better keep going. So thank you so much. And now, Tessa, we might bring you in and just along the same lines, but thinking of it as the impact for practitioners. So Lisa's spoken about Belinda, but what the impact for practitioners, what have you noticed about health justice partnership?
Yeah, thanks, Cathy, and thanks, Lisa. Just such a great example of what complexity looks like in someone's life in terms of the clustering of health, legal and social problems that Belinda was grappling with. And so, first and foremost, we're thinking about this idea of health justice partnership as a response to that complexity in people's lives, in the lives of patients accessing healthcare services, in the lives of clients accessing legal services, in the lives of the communities that our services are here to help. But as soon as you hear Lisa unpacking those layers of complexity, the building of trust, what that building of trust was able to do in terms of identifying more and more problems and often underlying causes, as soon as you start to understand that complexity for someone in their life, you also understand how much of a challenge that poses for our services, and particularly for health or legal or other services who are often set up as though problems are singular and episodic, and as though one instance of care or one relationship with one practitioner is what it's going to take to fix a problem. And so one of the things that we're seeing as we work with these health and legal collaborations around the country is that the complexity in a person's life is often matched by complexity in the service system. If you've got a housing problem, you go and see your tenancy service. If you've got a income support problem or a balancing your budgets problem, you go and see a financial counsellor. If you've got a medical problem or a range of healthcare problems, you go and see a range of healthcare services. So every time we've got a new referral and a new pathway to help, we're adding to complexity in people's lives. But we also hear from practitioners, our health and legal practitioners, that they feel that complexity, that we've often heard, for instance, from healthcare practitioners who might be hearing someone's story and starting to have concerns about someone's safety at home, starting to think that this is a person who's actually quite vulnerable in their home environment, but the practitioner themselves may have no experience working with family violence, may not have the questions, may not have the language to probe in an appropriate way, to delve into what's happening. And critically, even if they establish, as you did, Lisa, in the case of Belinda, if they do establish that family violence is a factor or coercive relationships at home are a factor, many of our practitioners don't necessarily know what to do about that. So part of what we're seeing through the strength of this partnership-based approach is that we're building the capability of our existing workforce to have more resources at their fingertips, to be able to probe and start to understand what else is happening in someone's life, and then to be able to use through partnership to draw in other resources, to bring in other practitioners who might be able to tackle those problems, even to get advice from practitioners. Often in the case of someone who is particularly vulnerable or who is particularly has had bad experiences with services in the past, so might have a low level of trust in services. Often if you're talking about people with that kind of experience, maintaining a trusted relationship with a single point of contact in a service is actually really important. And so you don't want to be adding layers and layers of referrals and layers of other practitioners into the mix. But for that core practitioner to have a holistic, a multidisciplinary set of colleagues to turn to get advice, we use the language of secondary consultation around what that looks like. So again, a whole range of ways that we're really building the capability of practitioners to respond to these complex, these multiple and intersecting problems in people's lives. And ideally, as we're doing that, we're actually reducing the complexity of the service system. So when we're thinking about this work, from Health Justice Australia's perspective, as a national centre of excellence supporting this approach, we're thinking about outcomes first and foremost for people accessing services, but outcomes in the service environment are also really important. And so the outcomes for practitioners who are grappling with this level of complexity day in, day out, who sometimes are really not well supported in terms of meeting, identifying and responding to that range of needs, we see that as a real opportunity for this kind of a partnership, and particularly where the partnership is the nub of a collaboration that moves you beyond a single service setting or even a single system setting. So, if you think about the alcohol and other drugs sector as a sector, the ability to build those partnerships with the legal assistance sector is about helping both of those systems work better together in responding to those multiple and intersecting problems in people's lives.
Thank you. There's one question, I'm just not sure. So just to the person that posted it, is this only participants in Melbourne? Is there a standard procedure in Sydney too? I just wonder if does that make sense do you need a little bit more information?
Well, can I pick up on that in terms of how I understand the question, and please let's invite some clarification if we're not getting to it.
Exactly.
I think, and it maybe sort of moves us naturally into where we were going to take the conversation next, which is to say that when we think about health justice partnership, we don't think about this as a single model of service, and we certainly don't think about this as a single kind of clinical or best practice approach. What we're seeing in the over 100 services that we're working with now around the country is a range of ways that health and legal assistance and often other services are coming together to collaborate. So I might just start by just helping our participants understand the spread of health justice collaborations across the country. So if you can see that map, that's mapping based on our latest data, which was actually 2021 data. That's mapping 109 examples of health and legal assistance services coming together under the broad umbrella of Health Justice Partnership. So you can see really strong concentration in Victoria and New South Wales. That's really, Victoria particularly is where some of the work was first seeded in around 2012, 2013, but we're starting to see growing interest around the country in this way of working. But having sort of established that there's quite a range of examples across the country, we also are really clear that there's a range of different ways that those collaborations operate. And so this goes to this idea that we think about this as an approach, and in some cases that approach is an example of outreach or referral pathway. In other cases, and Lisa's is a good example of that, it's a much more embedded partnership where you've got legal staff on site in a healthcare setting, part of the care team, on the email system, part of, if you're in a hospital, might be part of grand rounds. If you're in a community service, you might be part of multidisciplinary case conferencing and working together. You've got legal and health staff doing training with each other, building each other's skills and expertise, so that opportunity for the more embedded approach is, as you would imagine, a much more collaborative service response. But I think what's important in what we've found to date is that what works, for instance, in a regional setting where you might have a limited number of services available in the first place might be very different to what works in a place-based approach in a capital city. And that's actually really important. So ideally, what we're starting with is, well, what are the community needs? So let's be clear about what are the level of multiple intersecting health, legal and other problems that this community is facing. And examples of those needs might be, there are communities where employment legal problems are really high, particularly if you've got a community that is reliant on precarious work or shift work. We've got communities where immigration legal issues are much more prevalent because of the nature of settlement and who has settled in what areas. So you can often start by understanding what are the kinds of legal problems that are likely to be present in a community, in the same way that you can do a population or a community level health assessment. And then similarly thinking, well, what's the service infrastructure that we've already got in place and how can we help that service infrastructure work better? So the collaboration that works in Western New South Wales might be very different to the collaboration that works in inner city Sydney. And that makes sense because it's about making use of what we've got and helping them work better together. So that's how I would kind of give that initial response in terms of what does it look like and does it differ. Lisa, really interested in your reflections given that you've got experience in a couple of different services, and Cathy, please, if we haven't answered that question, let's get some more clarity from the questioner.
Yeah, so maybe I might just jump in and just say to the person that posted, if we haven't quite got it, write us another comment. And also I'd really just remind everybody we're really keen for any questions that you've got, if you'd like to post those in the Q&A, and we can ask those of Lisa and Tessa all the way through. So that would be great. Thank you. So Tessa, did you want to talk any more about, I guess, this about Health Justice Partnership across Australia, who does it, to add anything more?
Sure, thanks Cathy. Well, what I might do is just move us on to a sense of who are the kinds of services that are engaging in these collaborations. So, you know, for the example that Lisa has given us, there's many other examples of the services coming together on both the health and the legal assistance side. So we see a really broad slice of the healthcare sector really in these collaborations. We see examples, and in fact I've got a slide here that I might share to make it really clear for people. We see examples right across the healthcare system, from hospitals to community health services to Aboriginal community controlled health organisations and more traditional primary health settings. So as a model or an approach to integrated care within the healthcare context, we're seeing these collaborations emerge in a really broad sweep of settings. And that's one of the reasons that we're interested to have this conversation with the NADA network, to think about where alcohol and other drug services sit within that landscape, and to think about whether this is a kind of approach that might be helpful for you and for the people that you're here to help. On the legal assistance side, important to be clear that almost exclusively this is partnering with publicly funded legal assistance services. So whether that's legal aids or community legal centres, and those might be statewide legal centres like your Women's Legal Services, who do a lot of work around family law and family violence, or it might be specialist legal services like credit and debt and consumer legal services, who are focusing particularly on how people are able to access their consumer rights and are able to navigate their financial well-being in terms of credit and debt services. Whatever is the legal expertise, we're mostly working with publicly funded legal assistance services. We do have a couple of examples where the legal help is provided pro bono by a private firm. But again, if you're thinking about a partnership where relationships of trust are being developed across health and legal workforce, and where relationships of trust are being developed with the people accessing those services, you really need to sustain the workforce. You really need a sustained practitioner base in that partnership. So that's not necessarily a good fit for the sort of well-established private practice pro bono models where a different lawyer might come to a clinic an hour a month or an hour every 6 months. So just bearing that in mind in terms of what kinds of services we see across the landscape. So that's probably the starting point, Cathy, in terms of getting a sense of who is partnering. The other thing that it might be interesting to come to, but I'll pause in a minute, is thinking about the distribution between capital cities and regional spread. So I've got a slide to share when we come to that, because I know that certainly has been of interest to the NADA network in the past when we've had presentations at conferences and things. I'll just pause there. Thanks.
Thank you. So that's a really fantastic. We're starting to really get this picture of across Australia. What does it look like at the moment? That it's not a cookie cutter approach. There's no single health justice partnership that we all want to do exactly the same, that it's really based around local need, place-based approach. So that's as an overview. Lisa, what do you think Or can you talk to us more about if people are thinking, yeah, but what's it actually look like? How does it work on the ground? Could you give us an example?
Sure. I'll talk about our partnership with Windana Therapeutic Community. But across all of our partnerships, we deliver a sort of core suite of services, and they're the ones that Tessa's broadly referred to. So in terms of our direct services, sometimes we just provide information referral and refer the client for legal support via another agency. We also provide one-off legal advice based on the specific facts of that client's matter. And thirdly, we provide ongoing legal casework and representation. And from my perspective, it's in that last category where the magic of health justice partnership really works, and I'll elaborate in a minute. So for all of those services, and we also deliver services to our partner organisation, the secondary consults that Tessa talked about, and also training. There's so much demand for our training amongst our health partners. So for instance, last week we delivered a really great session on bail conditions, how to modify bail conditions, how to support your client's compliance with bail and what to do when they don't. So that was a really helpful session. We've done similar things in respect of family violence orders, et cetera, an ever-ending request for training by our health partner organisations. But to drill right down to the detail, at Windana, part of the intake process to Windana involves a very brief legal needs assessment that we've built into the Windana assessment process so that they are alert to the issue of legal need and can actually delve a bit deeper, because as we saw in Belinda's story, there was legal issues there she wasn't even aware of, her assault outcome. So it's about sort of asking some probing questions. Interestingly, we also find that a lot of the referrals from the Windana clients come through word of mouth, which is just great because a lot of clients have had poor past experience with traditional lawyers, wouldn't see a lawyer, as you noted, Cathy, in a fit, but the other residents say, yeah, I know her, she's okay, she did the right thing by me, and we get a lot of referrals through word of mouth. We have a very, it's an e-referral that comes through to us from Windana, importantly through one person only, and that helps us navigate the complexity of the therapeutic community and all the things that are going on there. We have a single contact point there who coordinates all of our activities, and we've found that to be really valuable. And equally, they refer into a single point at our end. It's a half-page e-referral, very minimal information, really straightforward. And what we tend to do is just pick up the phone and talk if there's any queries about the referral. And we guarantee to respond to that within a couple of days. If it looks like the sort of matter that we deal with and that we can help with, we'll schedule an appointment on site, the next available Thursday afternoon appointment on site, where we'll actually meet with the client directly. Our practice specialises in criminal, family violence and related family law matters, and will also assist clients in those categories who've got fines, infringements and victims of crime assistance matters. So we don't do everything, but where we can't do something, we guarantee to use our networks to link the person with a lawyer who can. And interestingly, picking up on Tessa's point about pro bono work, we lean on all our colleagues in private practice and we get them to do work for our clients. But we also know the lawyers who will work well in this space, who deal well with client complexity, who understand mental health issues, who understand how to work with people with complex intersecting needs. And there are some people we just simply wouldn't refer to. When we refer on, we always do that in a warm and supported way. Again, we'll normally talk to the lawyer first and say, we're referring this person to you, this is their circumstance, to prevent that sort of retelling and rebriefing that has to always occur. Where we can assist a client directly, though, we have that first meeting. And that's a really important part of us getting to know the client. Unlike a traditional legal service, we're not just taking instructions on the legal matter. We really do a deep dive into the client's circumstances, sort of all of their life domains. So that may involve 1 or 2 meetings or a very long first meeting, but it's very much about treating the person holistically, what's going on for you. And that can also give us a heads up on the unmet areas of legal need at the same time. We then explain our legal service and how it's different to a traditional model. We're really clear that they're signing up for something different if they sign up with us. And the 2 key points of difference that we stress are, 1, we require an exchange of information between the clinicians and ourselves. That's fundamental to the service model, with some important caveats that I can talk to later. And two, if the client signs up for our ongoing legal representation, a condition of that is that they're in treatment, actively working on the issues that brought them into contact with the justice system in the first place. That's really important to us. We are a therapeutic legal service that attempts to address those underlying drivers of contact with the system. Now, we make it clear that our service isn't for everyone, and if people aren't comfortable with that model, we'll help them connect to a more traditional legal service. If they are comfortable in that first meeting, we ask them to agree to consent to exchange information between ourselves and the AOD agency. And at the end of that meeting, that initial intake meeting, if we've had that consent signed, we then have a regular follow-up meeting with the clinicians and start to talk about how we might progress the legal matters. And that's when we start that process of timing the legal and therapeutic interventions according to the client's best interests. From there, we work hand in glove with the clinicians, assuming the person's part of our ongoing case management service. And that could involve anything from regular one-on-one meetings with the clinician, being embedded as part of the care team, attending clinical review meetings, being part of discharge planning, and from our point of view, relying heavily on the clinicians to provide us with reports that we can furnish to the court in support of various applications that we might be making. Sometimes we identify issues that we think are really important for the clinician to address as part of the therapeutic intervention, and in turn sometimes legal issues will arise through therapy that they will refer back to us. So it's a real toing and froing over the life of the matter that's quite important. Finally, when someone exits our legal service, we have a commitment to following up contact with them at 3, 6 and 12-month intervals, where we just check in and say, how are you doing? Is there anything we can help you with? Has anything happened since? And often in that conversation, they're using again, and we may well have the opportunity to say, do you want us to hook you back in with an AOD treatment? If not Windana, another service, what do you need? So it's an important sort of watching brief that we try to hold, which again is pretty different to other legal services.
It really is, yeah, wow. Look, I'll just, because as a panelist you probably can't see, but you're getting lots of thumbs up. And people, the words that jumped out at me were trust, and also this someone feeling like, you know, you're really talking about addressing the underlying causes and situation, which is, people are really appreciating that, Lisa. So while we're in the nitty gritty, I might keep you in the hot seat and just put some questions to you from the people that are watching. This is a question that comes up a lot for practitioners. So somebody from the homelessness person's legal service here, and they're currently piloting an integrated service at the moment. The thing they've struggled the most with is the lines between legal privilege and mandatory reporting, as most social workers are bound by the mandatory reporting. And we're all just smiling because we hear you. This comes up over and over. It's such a complex and understandable concern that people face. So yeah, any thoughts, Lisa?
Yeah, absolutely. And of course, we've spent a lot of time in our practice thinking through these issues. What I might get someone to post is the Federation of Community Legal Centres has developed a really terrific toolkit around integrated legal practice that talks directly to these issues, and we've used that material in our practice. In Victoria, lawyers aren't mandated reporters, and that means that we are in a very different situation to many of our health partners. We have really clear protocols that we develop with our partners around information sharing, what we share and when. What's really important in the health justice partnership space is the work that's done before a partnership kicks off to understand each of the discipline's professional and legal obligations, because they're very different. And I'd really like to elaborate on that a bit, because sometimes I know when we're setting up a partnership, our partner will be just chafing at the bit to make a referral to us and get a client in the door, and we're saying, wait, we can't do that until we've done some mandatory induction training with you, until we've sorted these protocols, these procedures, which deal with things like privilege. So we have detailed procedures that say, you know, we will have this part of the meeting where the health partner and the lawyer will be in the room, and then we might ask the health partner to leave the room, and this is what we're going to discuss, and we will cue you into that. So I won't go into all the ins and outs of the protocols here, but suffice to say that there are ways of working that can evolve over time where the partners understand the concept of privilege, understand mandatory reporting, and can work between those various obligations without, in my experience, it being overly problematic. The trick is to be alert to it, and that's really important. Can I just say, in practice, sometimes privilege and mandatory reporting aren't, in fact, the most, in my experience, the most challenging issues. There are other obligations that lawyers have that really seem so confounding to health partners. So, for example, a lawyer's primary paramount duty is to the court, not to the client. And that can sometimes really be confusing for our health partners who are used to operating in the best interests of their client. And we have this overlying paramount duty to the court. But again, it's about explaining that up front to our health partners before we start working on the ground. We actually have developed case studies from our own experience where that can be problematic. So people are attuned to it before they get down with real clients. And I think that that's been helpful to our practice. Similarly, things like secondary consultation, our professional obligations mean that we can't provide legal advice on the facts of a matter through a third party, through a clinician. So we have to be really careful about how we craft our secondary consults. But our partners who've worked with us over the years know that inside out, and we work around each other with a fair degree of dexterity.
I pick up on just a couple of those points from sort of picking up from where Lisa's left off and picking up some of the comment that's coming through the chat and the questions as well. And certainly from our experience having grappled with this issue about mandatory reporting and legal privilege right across the national landscape, we want to say, yes, that is a factor. And also don't let that be a barrier to collaborating. And often the approach, and this happens at the highest levels of government and then it filters all the way through to service policy settings and funding assumptions. Often the approach that's taken about things like information sharing is a really strong risk-based approach around privacy. When at the same time, we've certainly heard, for instance, in a lot of the work around family violence, that women do not want to keep telling their story again, that they want services to be able to understand the context in which someone is being referred to them or brought to them. So we actually see a real sort of challenge around how do you support person-centred approaches, particularly around complex need, with these very tight expectations around confidentiality and privacy. And so part of our answer to that, which I think Lisa's really alluded to, is to recognise that these are not just issues of law and policy, they're issues of culture. They're about workplace and collaborative practice. And so just really to back in what Lisa's saying about the importance of the relationship in a partnership, the relationship is what can help you navigate these problems. And they are challenges. There are many challenges working in partnership, and these are important ones, but we really encourage people not to see them as barriers. And I think then that, just to pick up some of the comments that have come through in the chat, you can see from the conversation that we're having why you might take a different approach around a health justice partnership to something like a referral pathway. So that idea that services would like to have their wish list of, not their wish list, would like to have a hit list of good lawyers that they can tap when they need one. I really hear that in the chat and the commentary. But in fact, if what you want is a collaboration and a connection around complex needs, you need a much stronger foundation of relationship between services for that to be effective. And that's where we're seeing this opportunity for a much more embedded partnership as a way to address problems that are not currently being well addressed. So I really just offer that as a reflection back to some of those ideas about who you might choose to partner with, how and why. I think that's really the first thing to sort of say in the context of that information sharing and privilege and confidentiality point, but conscious there's other questions to come to as well.
Thank you. Yeah, I'm just having a look. So I might jump to, there's a good question here, and it could probably be for either of you. So when Dana is a residential service and the person's asking what about for community services like counselling, and that they meet with us a lot less regularly, what are the expectations around the legal service working in conjunction with the AOD worker if it isn't as intensive?
Yeah, certainly one of our other partners, First Step, is a community-based treatment organisation, so the clients aren't residential. And again, it's very much a person-centred relationship. Regardless of setting, the intensity of the collaboration is dependent upon the client's circumstances and what they require, and it's navigated on a case-by-case basis. I think within the community settings, there are more opportunities for us to leverage other supports, which are really helpful. So again, we have very broad networks with housing agencies, with financial counselling services, with a whole range of organisations who we can bring to the table. But I don't think the nature of the collaboration is based on the service setting. From my experience, it's based on the client need. And there's just one point I wanted to pick up on from Tessa's comments a moment ago. We've talked a bit about how one of the benefits of a health justice partnership is the way that we can deliver legal training to the health partners. But from a lawyer's perspective, being embedded in a clinical setting that works with people who are seriously mentally ill, who have serious addiction issues, who are homeless, builds our understanding and expertise of those issues in a way that is invaluable. We as lawyers reflect on our past jobs in non-health justice partnerships and go, how did we do what we did then, not knowing what we know now? We have this capacity because of the way that we're working to build up a really rich understanding of, for instance, working with clients with cognitive impairment. We now ask for the psych report before we meet with a client with serious cognitive impairment. And often we'll talk to the psych or to their clinician and say, what's our best way of working with this client? How can we actually take instructions? How can we get consent? What are the issues that we need to be mindful of? Similarly, we get a really nuanced, layered understanding of family violence and concepts like coercive control and how they impact a legal matter. And we can then convey that to the court in our submissions. So there's a richness that comes from the partnering work that lawyers working in private practice just don't have that same opportunity to develop.
Yeah, it's definitely, it goes both ways, doesn't it? We often would talk about it, as you said, what the legal side might gain or learn from, but it goes both ways. I guess I was going to move us on, but maybe just Tessa, if there's anything else at that bigger picture level in terms of health justice partnership that you wanted to add before we move on to maybe some challenges?
Yeah, thanks. I think this question about what I'm reading in the question is a question about intensity. What's the intensity of the service response and therefore the partnership? And again, just to bring us right back to that sort of early idea we were talking about, that this is an approach. So partnership is an approach, and anyone who's had any experience in any form of partnership will know different partnerships take on different characteristics with different purpose. And so setting that at the outset is really important, but that can change as well. It can be fluid. And so it might be that, if you're thinking about what it would look like to work in this way, and you're thinking about what are the kinds of problems amongst the needs of people who come to your service, and what are the kinds of services you'd like to have a partnership with, you might just begin a conversation to get a sense of what services are out there, what kind of capacity they've got to pick up referrals. It can evolve over time. And so I think this kind of question about intensity of service and of partnership is a really important one. In the work that we do with the landscape of collaboration across the country, we see a huge range in terms of intensity. But exactly to Lisa's point, that's not necessarily determined by the setting. It's absolutely determined by the level of need in community and what services can do to meet that need. So if you've got capacity, if you've got the resources, if you've got the strength of relationship to bring a lawyer or a legal service partner into your AOD service in a continuing way, go for it. We are here to help. We would love to see that take off. But if actually this is a new concept, or you've had an experience that didn't work well previously and you need to feel your way, start smaller. Start with building the relationship between practitioners and working out what are the shared interests of working together, what might be even the shared client pool. It might be that your service and the partnering service are already seeing the same clients or patients or members of the community, or that there's different ways for you to experiment with working together. And so just in the understanding of what it takes to partner well, it's really giving yourself the space and the time to think that through. I wouldn't mind just picking up one other question, Cathy, in the chat, or in the questions, which is about the expertise, the different kinds of legal expertise that are available. And it really goes, again, to something that we see often across the services that we work with. So the question was about if your service sees a lot of women and children, particularly with family law or child protection issues, what's the kind of legal response you need? And is there a legal assistance opportunity that moves beyond family law and child protection expertise? And we see that as a really important part of setting the foundation for a partnership at the beginning. So on the legal assistance side, family violence services have often been funded as though family law is the only legal issue present in the life of someone dealing with family violence, when from the literature and from people's experience, we know perfectly well that issues around housing security, around employment stability, around credit and debt, all cluster around the vulnerability to family violence. And if you are expecting someone to see a different lawyer for each of those problems, you are, again, just adding to the complexity of the service system response. So there's not a recipe, there's not a magic bullet to this problem, but understanding the range of problems in your clients' lives, in your community's lives, and having that on the table at the outset of discussions with a potential partner is the best way to make sure that you build a collaboration that's actually going to address the unmet needs that you're seeing in the people that you're here to help.
Fantastic, thank you. As everybody says, I'm conscious of time. So we've got 8 minutes left. So maybe just to finish up, any wisdom, Lisa, we might start with you, around it's sounding pretty fantastic, this health justice partnership idea, but it can't all be sweetness and light. So just maybe one or two brief challenges that you've faced in this approach, and maybe how you overcame that hurdle.
Sure. I think we've touched already on a recurring theme, and that's the different frameworks, obligations, expectations, value bases that exist between disciplines, and so frequently we'll have different starting bases. Lawyers and health practitioners will often have a different starting point. And not just between practitioners and disciplines, but also between organisations. Each organisation values different things and has a set of different values that they bring to their work. And they can really become apparent very early on in a health justice partnership that there are differences that are there. We've talked about things like privilege, we've talked about mandatory reporting, paramount duty to the court. There's a number of those, and equally on the partners at the health partner side, they will often be very concerned about information sharing, about privacy and confidentiality. The best thing I can suggest from our experience is to try to head that off at the pass and deal with it early days in setting up the partnership, and then understand that you won't preempt every issue that arises, and have really good governance mechanisms and problem-solving mechanisms and dialogue set up to anticipate that there will be ongoing issues, but provide a way to work through them. We've talked a bit about, the formal stuff, but I think just nothing beats a trusting relationship on the ground. It is at the core of every good partnership, and one of the things that we'll often work very hard with our lawyers in-house is to say, never promise something you can't deliver, set expectations, follow through, do all the right things, because the only way a health justice partnership will work is if there's trust in that in that relationship, and that's been built up over time. I want to talk a little bit about the timing difference that we've talked about already, because that is a constant friction point in our relationship with our health justice partners. We'll say we've got a criminal matter that has to be, the court is desperate for it to be brought on, we can't adjourn it any further, and the clinician saying to us they're not ready to deal with that right now. It's totally counter to what we're trying to achieve through treatment. So there's a constant timing issue of where we're trying to make sure that as much as possible we're freeing up our client to participate in treatment in a way that's most beneficial to them. But in the background, we've got these, timelines that's running through the court system that we just can't quite nudge. So it's a constant negotiation, but again, having that dialogue very upfront with our partners and saying some things we can move and we can work in with the client, and other things we just can't, and you're going to have to come to the party with us on those ones. So that's a constant tension. Finally, I think that we've had some issues around being really clear that we don't provide legal advice to staff of our partner organisations, that really is a matter for the organisation to brief their staff on how they deal with a legal issue. And similarly, we've had two now really difficult circumstances where a client has sought our representation in a matter against our health partner. And we've, again, refitted our sort of MOUs and the like to make it clear that we just can't engage in that work because it's a conflict for us. So there's some of the issues that have been difficult, but good planning, good governance, MOUs and a commitment to the relationship, I think, gets us through.
Perfect. What a great way to finish. Thank you, Robert, for very subtly appearing. Tessa, did you need a last comment to sum up?
Two, if I may, but I'll be quick.
Right.
Just to offer a counter to Lisa's example around helping staff with legal issues. Again, example of the different cultures of working in partnerships. So we've certainly heard, particularly for instance in our work with community controlled organisations, that often that bridge of trust through staff is absolutely critical, and the ability to hear legal concerns and to help someone, potentially not with the direct advice, but to help someone navigate a legal problem on your partner's staff is actually a really key way to build trust. And the point about that is not that either one is right or wrong, just that the context and the establishment of relationships and trust is really critical. And so working through that as a partnership is part of what you need to do. Really just to finish out by saying where to from here, particularly for services and practitioners who might have been in this conversation and might have been thinking, okay, well, what does this mean for us? And that's part of what Health Justice Australia is here to do. So we've been really delighted to partner with NADA, and a big thank you to the team, to Rob, Alice, to Susie and others to put this event on with the NADA network. But if there are services who are interested in a further conversation about what this might look like, we run a whole range of training, coaching and other services, and we're also just always available for a first conversation about what this approach might look like for you and your service setting, and most importantly for the communities that you're here to help. Thanks, Kath. Thanks, Rob.
I might hand back to you. Thanks, Rob.
Thanks, Cass. Well, thank you, Tessa, Lisa and Kath. That was amazing. I remember when we first met Tessa and I was thinking, where have you been all our life? Like, this is the type of partnership that I feel our sector has, been wanting but not knowing that it exists. So I think this has been so exciting. I mean, there were so many things that I love that it focuses on the client, not on the service type. I think that's so important, and the outcomes for the client so they can focus on their health and having someone to support them. I just think it's a match made in heaven. So I'm really excited to see more health partnerships happening, health justice partnerships happening across our sector. So I know there's a lot of links that we're going to put into the chat function, and I think the good thing also is that we've recorded this, so we'll be able to share this to the broader NADA network and to other interested parties as well. And on that page, we'll include some of those links. There will be an evaluation, of course, that you'll be sent afterwards. So I encourage you to participate in that, and also just to reach out to NADA or I know that there's quite a few links in there. Reach out. We're happy to support drug and alcohol services, get engaged to think about what a health justice partnership might look like for you. So again, thank you so much for your time. Thank you to our presenters.